Welcome, everyone, to ASCP's Our Experience podcast. It's your host, Tom Hansel. But today, instead of our co-host, Chad, we've got a special co-host. It's ASCP's Executive Fellow, Dagmar Zajac. Did I say that right?
Yes. Thank you, Tom.
Dagmar, tell our viewers a little bit about yourself.
Yes. So thank you, everyone. My name is Dagmara Zajac. I am completing my 2-year postdoctoral fellowship with ASCP. So I am the Executive Fellow in Association Leadership and Management. I am very cross-functional. I am primarily in the GA space, so government affairs and pharmacy practice. And I'm so excited to be here joining you today.
Wonderful. Well, I'm looking forward to doing this podcast with you. But we've got a special guest here today. And if you don't know Mr. Joel White, let me tell you a little bit about him. Joel has an extensive experience on Capitol Hill, and he served on the House Way and Means Committee. He authored over 9 laws, and he's known as one of the main architects on Medicare Part D. Since then, Joe has led one of the most powerful healthcare consulting firms in all of Washington, D.C. So Joel advocates for pharmacy. That's why we have him on here, of course. And he helps push our agenda that keeps our profession at the forefront. So today we're going to talk to Joel. We're just a couple weeks before the election, and we're going to get his take on the landscape, regardless of who wins the presidency, kind of how that's going to affect pharmacy in our industry. So Joel, welcome. Tell us a little bit more about yourself and about Horizon. I know that you got the Coalition for Affordable Healthcare going. So give us some insight there.
Yeah, well, first of all, thanks for having me. I'm really excited to be here. It's obviously a busy time. I've been traveling all over the country the last couple of weeks, California, Arizona, Texas, New York. And the one thing that's the same across all those states is political ads, right? You can't escape them. They're everywhere, eating up your airwaves. But the good news is the election will be here soon enough, and probably shortly thereafter we'll know, what's going on, what the voters determine. I've been in the political arena for almost 30 years. As you mentioned, I worked on Capitol Hill for 12 years and was with the Ways and Means Committee when we gave birth to the Medicare Part D program, and that was a fun experience. I got to also work on the Medicare Part B reimbursement system, ASP, which affects a lot of providers and helps create health savings accounts. So if you have an HSA, when we first created those, we thought we'd be lucky to get to 1 million accounts. There's 35 million now across the country. So a really rewarding time to work with Congress and enact some major laws that are now affecting tens of millions of people. In positive ways. But then my wife told me to leave the Hill because it was a lot of work. And so I decided to start a small business in a highly competitive field, healthcare consulting in Washington, D.C. And so been doing that since 2007. And we represent clients from across the healthcare landscape, but do a lot of work in pharmacy in particular, and advocating for the needs of pharmacies and pharmacists, so that they have all the tools that they need to treat patients well, including getting reimbursed. And so one of the things that I did when I first left Capitol Hill, I wanted to make sure that we had platforms to elevate issues. And in 2008, was asked to run the Council for Affordable Health Coverage. ASCP is a member of that. And what we try and do is make coverage more affordable. It's pretty simple. It's in our name. I have to apologize. I feel like I haven't done a great job since I took over in '08 because costs continue to outstrip income. And so affordability is a real challenge. It's probably the number one health issue on voters' minds right now. And may help impact and determine some of the House and Senate races there over in the next couple of weeks.
Yeah, no, for sure. And we're just a couple weeks away from the big election. I know there's going to be a lot of turnover in the House. Obviously, the Senate's going to have less, but everybody talks about healthcare, but it's so broad. what are the main two or three, I think, primary topics that, regardless if it's Trump or Harris, what are the main two or three things when it comes to healthcare related to pharmacy that you think is really the most debatable?
Prescription drug pricing is the issue, right? Like it's the issue that's kind of scores the biggest on voters' minds and therefore politicians. The rollout of the Inflation Reduction Act and how that's going to impact pharmacy in terms of reimbursement, DIR, all those issues. Um, the real critical access to care. We see in a lot of communities care access dwindling, and pharmacy has a big role to play there. And I think elevating those issues is smart. But in terms of the big issues coming up in 2025, we've got the expiration of the tax cuts. We've got the expiration of the Affordable Care Act enhanced subsidies at the end of 2025. And don't forget, we got the debt limit, which is going to come winging in on January 2nd, 2025. So there's going to be a lot of movement over the next couple of months to kind of try and address that, put it off a little bit, and then come to a deal around some of these pretty big issues. They total up to about $5 trillion. That's a legislative vehicle and opportunity to kind of advance some of these pharmacy interests next year.
Yeah, and I do want to ask you, Joel. So, with that being said, because it is an election year, like from ACP perspective, so like our members, our pharmacies, pharmacists, like what what kind of, and as well, not taking it from like a political view, but kind of taking that out of it. Like, how should we look at it? Should we look at this election season?
Yeah, it's a great question. I think the first point to make is that the election has really been about personalities and style and kind of bickering more than it has been about issues. And the issues that are top of mind for voters and what we hear most from the candidates is really related to the economy and inflation and immigration. Those are kind of across party lines. Those are the big issues. Healthcare is kind of coming in at fourth, fifth, sixth,
Mm-hmm.
and so they're not really elevated. I would say the biggest healthcare issue that's linked to inflation is healthcare costs, right? And what we're seeing in part C and D, we're right in the middle of open enrollment right now. People are taking a look at their plan choices for to access prescription drugs, and it's kind of sticker shock, right? Like it's an average increase this year of 23% on the premium side, and plans left a bunch of service areas. So like 3 million people are going to have to shop for a new plan, and formularies are getting tighter. Cost sharing is going up, and deductibles doubling in Medicare Advantage. So it's really a cost issue that people are paying attention to. Um, I'm not sure politicians are paying attention to it, but like that's a huge issue.
Yeah. Yeah, and our seniors continue to grow in numbers, more and more and more. We'll have more seniors, obviously, in the history of the world sitting here at one time, and that continues to go up at a dramatic pace. I read an article that you just published here a few days ago in the Daily Signal, and you were given some pretty scary statistics at the end of the day. You mentioned the premiums going up, but number of plans have dropped dramatically as well. So there's less choices, but higher cost. And what I really liked about that article is you actually had some quotes from some seniors. I think one lady said, "My husband's premiums went up 650% because I live in whatever New York or whatever state that climbed dramatically." And so when we're sitting here as pharmacists and we kind of get focused on how IRA is hitting us, but the people that we take care of, it's hitting them now, not in 2026 and 2027. They're getting hit right now. Can you expand a little bit more on some of those statistics that you're seeing?
Yeah, so I think in the piece, it's on our website. If you want to check it out, it's on the Daily Signal website. Um, the, this is a much more expensive, more consolidated market with a lot more friction for consumers. So, what do I mean by that? Uh, the Inflation Reduction Act redesigned the Part D benefit, right? And we hear a lot about the $2,000 cap on out of pocket costs. Um, That made the benefit a lot more generous, but also made it more expensive. So the other thing the IRA did was shift risk onto plans, and those plans are now shifting that risk in the form of higher premiums onto seniors. So in 2024, we had a 21% on average premium increase. Okay. In 2025, we've got about a 23% on average premium increase. So since President Biden was elected, premiums have increased, I think, on average 57% in just a short amount of time. So that's like an inflation issue. It's a premium issue. It's like this is getting to be a much more expensive market. Also more expensive because cost sharing is going up. And so we see, retail pharmacists see people struggle with their cost sharing every day. A lot of products being moved up the tiers on the formularies, getting maxed out on either co-pays or co-insurance. And those formularies are getting, so that's like the cost. Fewer choices. Just going into 2025, plans took a look at the market and they said some of these areas are not going to be profitable for us to be in. So 26% on average plan reduction or actual plan reduction from 2024. So we have the fewest number of plans in Part D now than we have ever, but it's about 2/3 less than when the program was first started. And like I was there on the Hill, like I helped write that law. It was a team of people that pulled this thing together, and I remember very distinctly getting called up to Medco's offices in Franklin Park or Franklin Lakes, and the CEO and the senior executive team yelling at me in the boardroom saying, "These plans don't exist in nature. Like you guys are idiots. This market will never come to be. No plans will participate because it's like haircut insurance." And I go, "I'm bald. I don't really know what haircut is." He's like, "What are you talking about?" He goes, "It's like everyone's going to need a haircut every month. Like you can't insure against that risk. You're just dollar trading, or like people won't buy the insurance." And well, sure enough, we designed the program in a way where people actually found a lot of value in it. And they bought. We had 1,500 plans the first year of the market. We have about 500 plans this year.
Wow.
So it is just a dramatic consolidation in the market, dramatic reduction in choices. Seniors appreciate those choices. Different things are important for different
Certainly.
consumers. And then the last thing I would just mention is what we're seeing is a lot more friction in the market between the consumer and the plan. So one way to manage risk is to really tighten up those formularies and do more prior authorization, more step therapy. Like I said, max out on the formularies by moving products up the cost sharing list, doing step edits, like just doing outright refusal to do electronic prior auths, and then narrowing the formularies. So like this creates a lot of friction with the consumer. And I think one of the quotes that we had in the piece that you mentioned was, look, the drug's just not covered anymore and I can't
Right.
get it from another plan. So like, we're going to have to start paying $600 a month or something like that for this product. That's going to just get more frequent because while we can talk about all the benefits of the IRA and the $2,000 cap, we also need to balance that with the cost. And the cost is this is a much more expensive, more consolidated, more friction prone market for the average consumer.
So based on what you just said and your experience, when we're looking at IRA, Joel, can you tell us, depending on how the election goes, like what that may look like if Kamala Harris wins, or if Donald Trump wins? What does that mean for IRA?
Yeah, it's a great question, and I'll start with like there's not a lot of daylight between Trump and Harris on some of these drug pricing issues. Like they both support price controls, just different flavors. But the IRA was a highly partisan law, right? Like no Republican voted for it, and I think it's really about Biden said we stuck it to pharma, and it feels right now we're sticking it to seniors. That's got some political juice. Okay, so I know the Harris campaign says we want to accelerate the price controls in Medicare, and expand that $2,000 cap out of pocket to employer plans, I think the practical impact of that would be, a massive increase in private premiums and people losing their coverage. So if you think about, like, the House Senate will probably be pretty narrowly split. You're going to have to get something like that through a pretty evenly divided Congress. It's not politically realistic, in my opinion. The IRA is we're in chaos right now because of the IRA in the Medicare market. So my sense is after the election, there will be a serious look from Congress to try and fix some of these challenges, and maybe on the Democrat side admit that they didn't get everything perfect. Like, there are, like, real issues with how the law operates, whether it's for follow-on research or when price controls apply to certain products. A big failure of this law, it says that if you're a pill, a price control applies in 9 years. If you're a biologic, it applies in 13 years. So that's going to incentivize more biologics. Well, people have to go to the doctor or to the hospital to get those products, generally, if they're infused. Um, that's less access because pharmacies are in every community, but doctors are not. So
Hmm.
it's going to increase costs, so reduce access. That'll be a big issue that tries to get solved for. But on Trump, like, it's weird because he, like, supports price controls. So the question right now is, will he say, well, this is a Biden thing and he didn't do it right, so I'm going to put jet fuel in it and kind of really set it on fire, and I'm the negotiator, I'm the deal maker, and I'm going to make these price controls everywhere? Um, or will he kind of starve the program and not fund the bureaucrats, not let them kind of do what the law says they need to do? Because really, the IRA at its core is a step towards a public option. What I mean by that is the government's setting a price, in this case for a drug, and then letting the insurance company administer it. In Colorado and other states that have looked at public option, it's for hospitals and doctors and drugs and pharmacists, and then letting the private sector administer it. So it's like one step towards more socialized medicine, in my opinion. And so Republicans in general don't like that framework. So they're going to want to try and, there's still an effort to repeal the IRA outright because most voters think of it as a tax and a green energy bill, not as a healthcare bill.
Right.
I think if they do that, they're going to have to replace it with an alternative benefit redesign because you don't want to take away a lower cap on prescription drugs. So the answer, spent a lot of time saying it's really unclear. But these issues are going to persist. And the other issue that's going to persist into next year is how do these plans operate within Medicare, including PBMs and PBM reform, and how prices work there for both consumers and employers and pharmacies.
Yeah, I'm so glad you brought that up because PBM reform is obviously one of the key trigger words that every pharmacist around the nation spends time on their hands and knees praying for. But when you go to, and it's normal topic for us, but when you go to Capitol Hill and you start talking about that, give me the take. Like if I bumped into some congressman from Nebraska and I said PBM reform, are they going to go, what's that? What's the message there? Because at the end of the day, IRA was a way to try to control costs, but it's not the right way to control costs because we're targeting pharma. And if Congress understood that 80% of the monies for, when it comes to cost is being controlled by the PBMs, at least on the pharmacy side, that's the big elephant that you need to bring down. But they seem to almost push that away.
Yeah, it's. I think if you asked me that question 5 years ago, I would have told you 99% of members of Congress had no idea what a PBM was. PBM, what is that? Like, what is that? Like a candy? What is that? Um, Now you go up to the Hill, every single member of Congress that you talk to and say PBM reform, I know what a PBM is. Most of them, like the bill that passed the House, 350 votes or thereabouts, Right? Most of them support PBM reforms. And so the question isn't really like, do I support PBM reform? It's to what degree do I
Mhm.
support it? So I think that's very positive because there's much more sophisticated understanding of the market, that it's not just the price that the manufacturer sets. It's really the price. I think the ultimate concern for most members of Congress is, what is the price the consumer is paying at the
Yeah.
end of the day, right? So those are all really encouraging developments.
Yeah, no, for sure. And, back to CMS, who's somehow tries to stay aloof to managing any of this, but just kind of puts their directive out from my point of view. They seem to, as well, almost ignore pharmacy. They don't mandate dispensing fees and that kind of stuff. But at the end of the day, you can't take the healthcare system from top to bottom and say, "Hey, here at the bottom of the healthcare system's pharmacy, and we're just gonna let them try to fight for this big giant called PBM themselves." Why do you think that they've taken a real hands-off approach to even, you know, uh, I don't want to say enforcing, but they have done very little to even encourage or expect PBMs to really care for pharmacies?
It's weird. It's with CMS. It's more of like institutionalized culture. Okay, I think from the very start of Part D, it was that sense that we don't know how many plans will get into this market. We don't know how long they'll stay. We need to make sure this program works. So it's kind of just deference to plans, and that deference, I think, has been institutionalized and it's become a part of the culture. So CMS in general gives a lot of leeway to the plans. I mean, I know this was a tough year for the plans on the rate notice, or what the plans get paid, their updates, annual updates going forward. It wasn't as much as they expected, right? And so I think a lot of the plans took that as a hit. But in general, the agency works very closely with the plans. And the agency doesn't work as closely with the pharmacists. The view of pharmacists is that they're not really clinicians, right? They're not, they're dispensing medications.
Transactional, yeah.
They're counting to 30, right? Like, and for someone like ASCP, I think that like the value or the, like what you all bring to the table is that clinical expertise, right? And that view of what, that higher level skill and training that allows you to serve patients very well. And so I, I don't know how to change that, because I think it is organizational and it's persisted across administrations.
Mm.
Do you think, kind of being on the PBM reform topic, do you think anything could move before the end of the year potentially?
I do. I'm actually really hopeful. I think that if so, in my experience, when senior members of Congress get this educated on an issue, and they spend literally years, right? They've been working on this for 3 years, years of invested time, hearings, markups, amendments, floor votes. They don't just let it go, right? They want to do something. So the question is really what could happen in the lame duck, and so there's two sets of issues here, right? There's transparency and
Hmm.
there's money issues. Okay, that's how I think of it anyway. I bucket those two out. Um, so on the transparency issues, those are very important. We want to make people better purchasers in the market. They need to know some of the issues around rebates and fills and ownership and things like that. But transparency only gets you so far. Um, Transparency, though, is the common denominator across all of these bills, whether House or Senate, whether it's the finance package or the health package, the different committees. There's six primary PBM reform bills that were marked up in the committee process. They all include transparency. Uh, little different flavors in each one, but they're all transparency. So that's kind of like the least I think that happens in the lame duck. Okay, I do think that happens, or that's the goal. Um, on the money side, it gets difficult because then you've got these powerful interests that come in and they go trying to protect their pile of cash, right? So in this bucket, I would put like the spread pricing issue. Although that one, and I'll do this on a spectrum, so the ones I think are more likely to less likely. Spread pricing, I think, is more likely. So a bunch of the bills have a ban on spread pricing, which seem bipartisan support. It saves money on the federal side, which is always a good thing in this fiscal environment. Um, the next kind of issue that I would kind of put down the list is rebate pass through. So making sure that consumer, maybe a high cost chronic condition consumer, gets access to the lowest price, right? Their cost sharing is based on that lowest price. They get the rebate, the net price at the purchase point. Kind of the next issue is PBM delinking or delinking reimbursement to the cost of the drug, right? So
Hmm.
this would basically set out a bona fide service fee or a fee structure, administrative fee structure for PBM services, and would eliminate some of the real and perceived gaming that goes on to buy up prices to get more rebates to um, make more money or to keep premiums lower, as some argue. So that's kind of the spectrum. The money issues are harder. What I point to politically is there are senior leaders in the Senate. I'm going to put this carefully. There are senior leaders in the Senate who are very partial to the concerns of the PBM industry. And I think in the Senate, um, that to get something done, you're going to need unanimous consent or 60 votes. That means tend to go to the lowest common denominator because you're changing the status quo. If this were a
Hmm.
funding bill, I'd say it's like raking leaves. You're trying to get more things in the pile. This is the opposite of that. This is get to the lowest common denominator. So transparency, I think, happens. Delinking has got a lot of bipartisan support, so we're hopeful that delinking happens in the lame duck. And then last point, Congressman Brett Guthrie, who, if the Republicans retain the House, he'll be the next chairman of the powerful Energy and Commerce Committee, which is really led on this PBM reform effort. What he said is, look, we're going to get what we can get done in the lame duck, but we'll be back in 2025. We won't be done. Like there are ongoing issues here. The market changes. The contracting strategies change. We're going to have to do more. We're ready to do it in 2025.
Certainly, and I think another pretty large threat is these PBMs are so vertically integrated. They're now buying their own customers. So there's going to be another very large acquisition. We saw CVS, purchase Omnicare. We see other major PBMs purchasing mail order pharmacies and long term care pharmacies. And so, at the end of the day, because they're so vertically integrated, it's almost very non-capitalistic, if you will.
Yeah.
And so, they might take care of themselves, but not to the detriment of their other side of their business. And it seems almost like the FTC or whoever's just oblivious to how powerful these really are. They talk about BlackRock and State Street and all these big companies, but to me those big PBMs are the same thing.
Yeah, I mean, you said it. Three PBMs control 80% of the scripts, 80% of the market. Look, I think all of healthcare has gotten more consolidated, more concentrated. As a result, costs have gone up. We see it in hospital world. We see it in physician world. Almost half of all physicians now employed by a hospital. We see it in pharmacy. Like a lot of the stores are closing. Um, Independent pharmacies really taking it on the chin. We see it in the nursing home world. Um,
Mm.
and we certainly see it in insurance. We talked about the Part D market. We're seeing it in the commercial side. Um, here's the bright lights of hope, though, the little stars that may shine through in the night sky.
All right.
Um, FTC has taken this on as an issue, right? Like they've done a 2-year investigation. They've actually brought suit against the three biggest PBMs for violation for market violations. Um, I think I have no idea how that will turn out. I've been told by some people it's kind of a weak case, and they did a 5A kind of like they had more enforcement powers than they're currently bringing in that suit. So they could certainly do more. Um, the other bright light that I would say is Congress again. Part of this lower cost, more transparency bill that's passed the House, that's on the table for the lame duck, includes a number of competitive market reforms, and then uh, the Better Health for Lower Costs Act was marked up by the Ed and Workforce Committee. That includes a number of competitive market reforms to get at some of the concentration that's affecting the market. That's probably a next year issue from Michelle Steele. Look, there is recognition from Congress that we are dealing with a highly concentrated, uncompetitive, in many cases, monopoly markets, and they want to address it. So we've got legislative branch, we've got FTC, and then we've got the administration. And I would expect, based on the election, um, look, there's this anti-corporate sentiment on both for both parties. They're going to try and use their regulatory tools to kind of address those issues.
Well, I did want to talk about ECAPs. So, obviously, Equitable Community Access to Pharmacist Services Act, kind of similar with PBM reform. I mean, this is so important for all pharmacists. This would, continue to have those access to those essential pandemic services provided by pharmacists. Joel, I mean, what do you see kind of similar to what I asked you about PBM reform? Do you see anything happening with ECAPs before the end of the year?
Not this year. I've got to do a mea culpa. Okay, when we were putting together the Part D law in 2003, I had a meeting with John Coster, who was working for the Independents at the time, and we were trying to design the medication therapy management program. And the argument was give it to the pharmacists, and we ended up giving it to the plans, and that was a mistake, in my opinion. I think there were a lot of reasons to do it through the plans, like they're tied to the beneficiary in an insurance context. But what we've seen with MTM is it's been not very effective, right? And part of that is because if a beneficiary gets a call from a pharmacist, their pharmacist, they are more likely to trust them and to respond, maybe to adhere to their medicines or come in and talk about their drug list or any kind of problems. They get a call from a vendor or a plan. They're like, I don't know who you are. Like they may not even know they're with United Health Group.
Right.
I'm on the AARP plan. Like, why are you calling me? So that would have been a toe in the door to get reimbursement for pharmacy services. I think the ECAPS bill is smart. It narrowed the focus to look. This is what we're already licensed to do, and it set up a reimbursement structure that would guarantee savings. So I look at two things: the staffing shortages, and access issues. And we have got a 10-year trajectory in this country where we don't have enough physicians, nurse practitioners, ANPs. Like we just don't have enough people to care for the population, and there's not enough coming through the pipeline. So, in my opinion, what we need to focus on is kind of three things to elevate ECAPS next year. The first thing is access. How are we addressing the access issues? From a Republican perspective, that's more of a rural concern. From a Democrat perspective, that's more of an equity concern. What we see is many communities don't have access to a doctor, but they have access to a pharmacy. The second issue is really focusing on cost. How can these services be delivered in a cost-effective manner? And we know at the pharmacy they're efficient. They can get reimbursed at a rate that's probably less than the physician office, and it's more convenient for the patient. So it's just more efficient. And then the third thing I would focus on is the clinical skill. We still have a problem with regulators in Congress not understanding that pharmacists deliver clinical services. Okay. We got to get over that. Like, until we get over that, they're going to keep thinking these are pills. That's what I see. Like, I don't understand all the stuff that goes on behind the scenes. We need to do a better job educating people about what these services are. The depressing thing to me, and I'll just wrap up with this, we came through COVID where we saw test to treat. We saw
Right.
pharmacy stepped up in a massive way. And to put that down and put that aside and not say, like, wait a minute, we tried this, it worked really well. It didn't break the bank, and it dramatically expanded access to these clinical services. We need to push that point big time next year.
Certainly. That's a great point. Well, Joel, this has been amazing. Thank you so much for taking this time with our listeners. They obviously have a lot of concerns about IRA and their growing population and the threat of PBMs being their competitors. So just leave our listeners with some thoughts on how a pharmacy should protect themselves. We are in right before the election, but regardless of who wins the election, the 2026 IRA window there is coming fast approaching, like the Titanic headed right towards our iceberg, and we're all very concerned, obviously, and we know that the wheels of justice move slowly on Congress. So if you own a pharmacy, if you're a pharmacist, what advice would you give them to kind of protect themselves and prepare?
Protect and prepare. Well, the rules of the game are being set by people in Washington and in state houses, right? And the reimbursement is really tied to the rules that those people are making. You've got to be engaged. And what encourages me is that there's an incredible amount of power pharmacists and pharmacies have. There's a nursing home almost in every congressional district. There's a pharmacy in almost every congressional district. Meet with your member of Congress when they're back home. Don't come to Washington. I mean, come to Washington. You should. But meet with them back home. There's more power in that. Become very, very active and visible. And do it in a positive, proactive way. Like, we want this opportunity to serve people versus you're an idiot and you don't understand the issue. But use that power. Be very active locally. Raise your visibility and speak up, because unless you do, they're going to pay attention to the doctor or the hospital or the PBM or someone else that's banging on their door. So it's really in our hands. If we take the opportunity, I think we can be successful.
It's a great word.
Yeah, thank you.
Dagmar?
That was a very awesome way to leave it for today's podcast. And thank you, Tom, for having me today in place of Chad. It was a great time. So thank you.
You're a much better version than Chad, so
Gosh,
happy to do it.
thank you.
Don't tell.
Dagmar,
No, let's not tell Chad.
no. Dagmar, I know that we have at the annual event, we have the info on Farmer Workshop. I don't know if you wanted to leave our listeners with anything about that, but I know that's going to be a big discussion or group.
Yeah, most definitely. Yeah, each year ACP delivers business industry half-day summit that brings industry leaders to provide insight into healthcare. I mean, as it relates to our long-term care settings. This year, we do have a critical agenda speaking on the various issues LTC pharmacy is facing with impacts from the Inflation Reduction Act, the American Rescue Plan, and downward PBM pressure on reimbursement for the services provided by long-term care pharmacies. But yeah, I'm not sure if you want to add on to that, Tom.
No, I think that you might have a code. So if they get a hold of you personally, you can give them some kind of discount or savings or coupon or some sort. So I'll put them calling you there to get discounts. But annual event just right around the corner. We're looking forward to seeing everyone. And Joel, thank you so much for your insight. And we're excited about what's on the horizon. So
You're welcome. Great to be here.
Thank you, Joel.